Welcome to the NewlyMeds Podcast. Any views or opinions expressed in this podcast are our own and do not reflect the views of our employers or affiliated organizations. This content is for informational purposes only. Always follow your local policies, protocols, and medical direction.
What is up, guys, and welcome back to another episode of the NewlyMeds Podcast. As you guys are tuning in, you're probably seeing that I am wearing an Eagles jersey, and I hope that at this point you would know Dan and I are not recording on the day these episodes come out. So I am fingers crossed that this does not jinx anything tomorrow and that our birds are progressing well through the playoffs. But we've got a great episode for you today. Dan and I are going to do a little bit of a precursor to something in the near future that I think a lot of you are going to love. And this is going to provide some really good basics to understand where we're going in our next topic and give you a little bit more background of some things that are brand new or newer to the EMS world. So, Dan, what's up? How are we doing? And I'm pretty excited to get after this today. What about you?
I'm super excited as always. Anytime that we can sit and kind of nerd out on medications, I'm always a big fan of that. And like Will said, we've got a very exciting one coming up in the very near future, and this will kind of give some of the pharmacological background, so that way we can spend more time in the next episode really getting into the weeds with what some of these medications are going to be for. So with this episode, we're going to kind of go back to a couple quick crits ago when we did a real in-depth Pharm review, and we're going to go back at that again.
Yeah, Dan, absolutely. So I kind of want to just jump us in right here and talk about what we're doing today. So we're doing what Dan said. We're doing a Pharm review, and we're really only going to be looking at two things. And one of them is fairly new to a lot of EMS systems. Those of you who have been in EMS a long time probably remember this medication from years ago, and then they kind of took it off the truck, and now it's making quite a comeback, as it should, because it's a proven medication that does a lot of really good things for our patients. So I'm going to be talking today about Levophed, or norepinephrine, and Dan will be talking about our second medication. And we are going to try to get really deep into this, but also keep it pretty quick. So hopefully you bear with us on it and you get a little bit of the takeaways. And if it does go a little bit over your head, I would urge you to just give a listen back, maybe pull up some of the resources we talk about today on your computer and listen along with us as we talk about it. So what is norepinephrine, or Levophed?
I don't know. Will, could you tell me, please?
I would love nothing more than to tell you, Dan. So
Excellent.
Levophed is what we consider sort of an inopressor. It's a catecholamine, a neurotransmitter, a vasopressor, and an inotrope. And so it sort of fits into that inopressor, where it's a vasopressor and an inotrope, which really means that it does a lot of beautiful things for our patients who are in this shock state. And so at a very broad spectrum, I always like to refer to the MCRIT pressor rapid reference. I think it does a great job at diving in deeper to some of these. But Levophed, in the grand scheme of things, has a lot of alpha stimulation and a little bit of beta stimulation. And so what that means is that it's going to increase our heart rate. It's going to increase that ventricular ectopy that we have, that squeeze. It's going to increase our systemic vascular resistance, which is in turn going to increase our cardiac output. And ultimately, obviously, as we're doing all of this, it's going to increase our blood pressure, which is the goal of Levophed. In our shock state patients, we really want to increase our blood pressure and our cardiac output. And so it does that by acting as a peripheral vasoconstrictor. It acts on those alpha adrenergic receptors. It's going to cause inotropic stimulation of the heart. It's going to dilate our coronary arteries with the beta-1 cascade. So it's going to work in there. It's made in our adrenal medulla. And it's not just a vasoconstrictor, really. So you're going to have these three key aspects to it. You're going to have that alpha-1 agonizing aspect with our vascular smooth muscle causing that vasoconstriction. You're going to get some beta-1 stimulation, which is going to increase our contractility and heart rate. And then there's a little bit of beta-2 stimulation. It's also going to have alpha-2 stimulation, which is going to inhibit that feedback loop of the norepinephrine. So it's going to stick around and give us some really, really good things. It's going to increase our contractility. It's going to increase our venous relaxation, in turn increasing our blood pressure. And so a little bit of background on norepinephrine is that it's actually derived from dopamine. It's a natural precursor to epinephrine, which shouldn't be a huge jump in a loop. We know that we naturally produce epinephrine and norepinephrine by that adrenal medulla. And it's a widespread central and autonomic neurotransmitter. And so when we actually look at this medication, I talked about some of the effects that we're going to have. Why are we seeing it more in the field? And why is it such a good medication? Well, realistically, it is going to provide so much initial increase in our cardiac output that it really does so much good for a patient who's in that shock state. It's that first line pressor. It's going to cause that calcium flood that's going to increase our myosin cross bridging and tighten down that vessel. So all that smooth muscle is going to contract. Our arterial diameter is going to get smaller and our systemic vascular increases. So that's why Levophed is really good in that sense. So when we look at the system-wide hemodynamic change, we're going to see an increase in our mean arterial pressure, our MAP, which is a huge marker for Levophed titration. We're going to see an increase in our cerebral perfusion, our coronary artery perfusion pressures, and our renal perfusion pressures. And when you look at any data with shock, you're going to see that Levophed is first in septic shock, which as we progress through this episode, I think is going to be something that you're going to see a lot more discussion on, and it's going to even lead into Dan's segment a little bit. But I threw a lot of big sort of cellular level things about Levophed. So now let's look at it as a broad picture. Some of the considerations that we have with Levophed, some of the things we want to look out for when we use it, some of the side effects even. So we could see some dizziness as they're on it, cardiac arrhythmias. As we're using more and more Levophed, you might see some bradycardia, some severe hypertension. It is a vesicant, which especially in the EMS world, we don't really consider a ton of when, especially on the 911 side and the non-critical care side, because we're really only putting in peripheral access. But you really have to understand that running Levo for long periods of time through a peripheral IV is not smart. We should be running this through central access. If that peripheral IV extravasates, it can be really toxic to the person, and Levo is naturally toxic to the veins. So running it for short times in EMS, definitely acceptable, but monitor that IV site closely, make sure it doesn't infiltrate, and that we have a big problem when running that norepinephrine through an IV. And as you get to the hospital, one of the considerations on the nursing side of the house is anytime we use pressors, because we're causing that tissue hypoxia, you might have a little bit of an increased lactate with it. Some of the big things we want to think about, again, always follow your local protocols, but anytime we're starting to see Levo in those double digits, the patient is pretty critically ill. So you'll see a lot of protocols that start Levo at 20 for post-arrest or peri-arrest. For your shock state patients, you might see it start at 10, but we really don't want to see Levo over 50. You might see it maxed out at 100 in some literature, but at those points, we're going to start talking about getting some additional pressors on board and turning that Levophed down, because as we turn that Levophed all the way up, we're going to start creating some systemic problems that we don't like. We're going to start shunting off a lot of major organs that we don't want to shut off when using it. And so with that being said, that's a little bit of the down and dirty of Levophed. If you're going to take away some things in here with it, remember that it causes a lot of really good squeeze in our body, sometimes too good. So as we're running Levophed at high doses for long times, make sure that you're monitoring the skin, their fingers. Understand that they might have some decreased urine output. As it's really good at vasoconstriction, we're going to lose those kidneys. And as well as the gut, we're going to start creating a lot of that hypoxia with that good vasoconstriction that's causing some negative effects. Titrating to a MAP goal, I always really see in the ICU MAP goals of 65. That's where we're getting a lot of our cerebral perfusion and good organ perfusion at 65. So if you are above that, maybe it's time to turn that Levo down a little bit. But the big takeaways here is that Levo naturally produced in the body a good bit of alpha stimulation with a little bit of beta stimulation. You get a lot of squeeze, a lot of constriction, and it actually doesn't affect the heart rate really significantly until we get to those higher doses where You might see some tachycardia or some bradycardia, but really Levophed so good because it just improves the blood pressure without touching that heart rate a ton. So Dan, that's a ton. We knew this episode was going to be heavy on a little bit of that cellular stuff. I would urge you to listen back to that section, follow along with some of the references that we link, and understand that deep patho of what norepinephrine is. We're starting to see it pretty widely adapted in the field of EMS. It's obviously been in the hospitals for a long, long time, and it's been around for a long, long time. Dare I say, since the dawn of time, since it's something that we naturally produce on our own. So Levophed's been around. It's has a proven track record of doing a lot of good. And I think it's critical to understand the when, the why, and the how behind it. Dan, I know you got some medication that you want to talk about. What are you going to tell me about today? I knew I just threw a lot at you. So
Yeah, absolutely. We're going to go even more into a cellular and cellular level and talk about bacteria, because I'm going to be talking about Ancef, or our cefazolin. If you are a biology major, maybe you turn this off here. I am not a biology major, but in the next 5 or so minutes, I'm going to try and give you the deepest dive we can in the shortest amount of time period that we can, to really explain what an antibiotic does, especially one like Ancef, or broad spectrum antibiotic, and why that's so important for us in an EMS realm when we really haven't been seeing antibiotics. We really haven't been incorporating that into our care until relatively recently. Maybe some critical care services have been for a while longer, but just at our street level providers, we haven't been seeing that until relatively recently. So we'll talk about Ancef really quick. Some background on that: it is a first-gen cephalosporin and a beta-lactam antibiotic. So what this is on its face is a cell wall synthesis inhibitor, which will make sense here in just a second when I explain why that matters. And it is also bactericidal, meaning that it's killing the bacteria and not just inhibiting or preventing the bacteria from working. Essentially, Ancef's job is to make the bacteria explode. So how does it do that? Well, let's first start with what Ancef is going to target. It's going to target a wide range of our gram-positive bacterias, so our MSSAs, or our Staphylococcus aureus bacterias, as well as our strep species, skin flora, surgical site organisms, and then it will have a more narrow but still a range of gram-negative bacteria as well, including things like E. coli. And this wide range of different bacteria is why this is the number one surgical prophylaxis antibiotic, and one of the first go-to frontline, front-loading antibiotics that we'll be seeing used. So how does it work? We have to understand on a very basic level how bacteria works. And bacteria survives because of their cell wall. They have this rigid mesh wall built up of sugar chains that are cross-linked by peptide bridges, and with that wall is what essentially gives the bacteria its shape, as well as it keeps the osmotic pressure from rupturing the cell. So that's kind of keeping all of the bacteria together. When we look at that cellular structure, that bacterial structure, we also have to look at the enzymes that build their wall. And those are PBPs, or penicillin binding proteins. And these are going to link those chains together. And essentially it's going to think of it as a brick wall. These PBPs are going to link these together and bricklay those out, forming that bacterial chain. Again, if you're a biology major, I'm probably making you cringe, and I'm sorry, but bear with me. So at this molecular level, cefazolin has a beta-lactam ring, which is going to mimic that PBP, that peptoglycan substrate, and it's going to kind of try and trick that PBP, or that bricklaying enzyme, right? So it's going to ultimately these PBPs are going to bind to the Ancef instead of the building blocks that it was trying to bind to. Once this Ancef binds to the PBP, that enzyme is disabled. That has essentially shut off that chain, and that is now an irreversible process. It's an irreversible enzyme inhibition. This process is now disabled and it cannot go any further. But if you recall, when we first started talking about this, I didn't say it just inhibited, but it also kills the bacteria. Well, as this bacteria keeps trying to grow and divide, it can't. It can't cross-link these PBPs. The walls start to become weak. And because of that compromise within the wall's integrity, the cell wall's integrity, the osmotic pressure starts to build. And as that osmotic pressure starts to build, the cells lyse, or in cooler words, they explode. And that then effectively kills off that bacterial chain. So not only are we inhibiting the spread of it, we are then killing it from the inside out, the bacteria, that is. So because we know how Ancef disrupts the chain and then causes the bacteria to essentially explode through the process of that we talked about, what that bacteria, if it's not actively making new cell walls or trying to divide and grow, Ancef's not going to work. So Ancef is only going to work on these bacteria that are growing and making new cell walls. This is also why it's best, and this is why we give it pre-hospitally, prophylactically, as well as in the hospital, ICUs, surgery, anytime where you think you might need an antibiotic. This is, again, it is the most given prophylactic antibiotic, because the earlier the better, because we can really get in there and we can really stop that chain and kill that bacteria off. We can also give this antibiotic so early because human cells are safe. We don't have these cell walls and PBPs, and it doesn't go through that same process. So it's only actively targeting essentially these bacterial cells that have the structure that we talked about. So it's extremely selective when it comes to bacteria versus human cells, and that's why it is incredibly safe for us to give that versus some of the other antibiotics, which we're not going to go in and get into, but how some of the other antibiotics work. There might be other cells, other enzymes and stuff like that are involved. And that's why those are a little bit on the, I don't want to say less safe side, but potentially could cause more side effects or harm. When we think about what's happening after we give this, 90% of this is staying in the plasma. It's going to distribute out to the skin, the bone, the muscles, the lungs. But Ancef is not metabolized, but it is ultimately cleared by the kidneys. And that's why, again, with most of our drugs, we need to be careful and making sure we're dose adjusting for our renal impaired patients, because this is ultimately cleared by the kidneys. We talked about all of these bacterial straits, but this also does work on skin flora and open wounds. It's very important because this ultimately sterilizes tissue planes and prevents the bacterial adhesion. And then again, any bacteria that does form, it disrupts that chain, but it can, again, especially if we're giving this prophylactically, it stops potential early colonization of these different skin flora and bacterial infections. So we give it before incision and immediately, or as immediately as we can after trauma. I did note that it's more so for like the MS assays. So for our MRSA patients, it's not going to be as good for those because of the PBP structure. It's not going to work in the same manner. So it's not going to be able to bind to those MRSA cells. So it's not going to be effective there. That's why Will gives a ton of Vanc in the ICUs.
Absolutely not.
But yeah, I think when we think about it from an ICU perspective, we essentially can be seeing this given for bacteremia, wound infections, hardware infections, any type of like osteomyelitis, any of these first line defense drugs, and that's why we're now seeing this being rolled out to pre-hospital as well. We're seeing this being rolled out in trauma with
Yeah.
open fractures. We're seeing this being rolled out in sepsis type patients, which if you've made it this far, you've probably pieced together that maybe that's where the train of thought we're going to be going down here is our sepsis patients, considering that we've been talking about levo and antibiotics. But I think Ancef is a fantastic medication that we're going to be seeing significantly greater push for in the very near future, especially with more progressive services.
Yeah.
And I'm super excited because it's one of those things that it's not necessarily something that we will see on a pre-hospital side as far as the effects and the benefits go, but we will definitely be able to really potentially have an impact on that early recognition, early treatment, and increase in survivability.
Yeah, Dan, I think one of the huge takeaways from what you just said is in the ICU, certainly we give plenty of Vanco, plenty of Ancef or cefapime, and that's the one thing that I would urge our viewers to look at is why is Ancef or really any cephalosporin one of the first line antibiotics? And a little hint here, it's because it's such a broad spectrum. One of the things that we have in the ICU that you don't have in EMS is the ability to wait for cultures to actually culture in the lab, so that we know what we're looking at and we know as these cultures grow, what should we use to treat. And so we can get really selective with actually our antibiotic dispersion in the hospitals and using them and being good stewards of antibiotics. But as far as critically ill patient goes, if you've gotten here, we're talking about Levophed, we're talking about Ancef or any cephalosporin. One of the things that we've said almost all of season 2 and even to start out season 3, and I know I mentioned it when Dan wasn't here in season 1, it's because it's so commonly seen are patients in the field who are most likely septic or pre-septic. And as we get more data and more literature, we see how fast of a progression sepsis is. And you also see the data showing how negative outcomes get with just 1 or 2 episodes of hypotension, hence the Levophed, and also the literature proving that that early use of antibiotics is so critical to improving the patient outcome who is suffering from sepsis or septic shock. And if you are seeing your septic shock patients in the field, immediately starting fluid resuscitation and vasopressor therapy is going to be a huge, huge indicator of survival from what is a very, very lethal pathway. So, Dan, I think you really hit it hard on why Ancef does what it does, but really, when we look at these broad spectrum antibiotics, why they are so good for humans, especially when you don't have the luxury of having a lab run your cultures for you and understand what bacteria you're actually growing inside of your body. So,
Right. And
I think
Will, if I can, real
yeah,
quick, just
absolutely.
one thing I wanted to add that I forgot to mention, as with anytime we're thinking about antibiotics, we are obviously concerned of a potential allergy. I know we did talk about there being no concern as far as the destruction of human cells goes, but the way Ancef works with that beta-lactam ring binding to the host proteins. With that binding, you can have an immunoglobulin E response. So when we first learn about Ancef, they say if they've had a severe penicillin reaction before, that IgE response can cross react essentially with a penicillin allergy, more typically a more severe allergy. And that's more in the 5 to 10% range of that cross reacting with a penicillin allergy. So, do with that information as you wish. It is more leaning to the more severe side, and that is a potential cross reaction based on the IgE response.
And always use your clinical clues. And if you're doubting it and you don't give it, I think that that's perfectly fine. And if you're doubting it and your patient can't actually answer if they have a severe penicillin allergy and you do it, um, you know, I don't think it's the end of the world. These patients, if they are so critically ill that you're considering some of these interventions, we want to make sure that we're doing everything we can in our power to improve patient outcomes. So use your local protocols, your state protocols, your national protocols, but more importantly, use your judgment. That's what's going to get you really far in medicine, is just use that gut instinct in all the school and time you've spent, everything that you've learned, the interactions that you've seen in your career. Use that good clinical judgment that everybody listening to this podcast has. Anything else, Dan?
No, I think that's it for me. I'm looking forward to, now that we've covered the Pharm, I'm looking forward to getting really into the weeds with whatever topic we might be teeing up with these two medications. So
Yeah, I think it's a huge mystery about what we're going to be talking about here in the near future, but it is that mystery is one you definitely will not want to miss. So
absolutely.
can't wait to see you on that one.
But yeah, thank you for the meantime. Thank you guys for listening. As always, make sure you check out the TikTok, the Instagram. We're going to be putting up some new things in the very near future that's going to be specific to Instagram and TikTok and over on YouTube Shorts as well. So make sure you're keeping an eye out on those. You'll be seeing more information only over there. So make sure you check those out. And in the meantime, as we're getting ready for this mystery episode coming up, just remember to trust what you know and treat what you see. Stay curious and stay humble. Catch you guys on the next one.